Good morning, everyone. I want to congratulate Mauro for a wonderful presentation and for reminding me how old I am. I also want to congratulate you, the audience, for finding this room. And I want to congratulate the audience that is looking on through the web as far as attending this meeting. So, you have seen the science behind the use of ISQ. It's my job to show you how the ISQ scale is used in daily practice. I use it to improve my success. I use it to reduce the treatment time for my patients. I use it to avoid premature loading. I use it to improve predictability with high-risk patients, and I use it to determine when to proceed with the definitive restoration. This entire list is used to improve the success rate overall, long-term wise, for our patients. If you in the audience really want to be critical as far as improving the outcomes for your patient, then you have to use some objective way to determine when that implant has achieved biologic stability. And if you've ever attended any of my training courses or my advanced clinical training program at UCLA, you know that every single implant that I placed over the last 15 years have been measured with ISQ. And at this point, the reason why I take these measurements is because we are seeing more demands from our patient as far as earlier and earlier treatment times. We're also seeing the pressure that are placed on us as clinicians from the implant companies, because they're the ones that are sitting out there right now telling our patients that they can get their tooth or their bridge sooner. And we're also being pressured by our competition, because many of the patients come in and say, well, Dr. So-and-so said that I can have my results right away. And all of a sudden, we're sitting there going, okay, we want to treat you as our patient, and we need to deliver what that doctor promised down the street. And so this is the reason why we need to take measurements, because if we are going to provide answers for our patients, we have to know how stable that implant is. We need to know whether that implant is solid enough, stable enough to provide immediate loading, or is it stable enough that we can perhaps go with earlier loading, or must that implant wait a specific period of time, or what we call traditional loading. We also have to be able to detect when an implant is having troubles, when the implant is not integrating in the proper rate, or at this point, if it has integrated at all. So the key parameter for success, as Mauro has pointed out, is the achievement of initial stability with the implant and maintenance of that stability throughout the functional life of the implant. That was determined by Professors Albrechtsen and Zarb way back in 1993. Well, how are we supposed to achieve that success if we really don't know what that stability is? We've already gone through the different ways of measuring implant stability. And as Dr. LeBlanc has indicated, insertion torque has been used quite frequently and for an extended period of time. There is many research projects that correlate the value of using insertion torque with predicting how the implant will survive or succeed. Unfortunately, as he has already mentioned, it is a one-time measurement. And for that matter, if you are able to insert an implant at an insertion torque of 38 Newton centimeters, what does that tell you, really? It really doesn't tell you anything, except how dense the bone is and how much resistance you're getting by placing the implant. And I was taught the traditional method when I took the first training course back in 1983 with Professor P.I. Bronemark. I saw him tap on that implant, and I kind of looked and said, "What are you listening to?" "I'm listening to how stable that implant is." Well, unfortunately, I'm tone deaf, so I can't really tell the difference between a high-pitched ping and a low-pitched ping. So again, as you have pointed out, it has fallen on the experience of these hands, and by the way, they can be bought. So, the advantages and disadvantages of the traditional method: it seems to work. It is inexpensive. You can tap all day long if you want, so it's reusable. And it's low maintenance. The problem, though, is its low sensitivity, poor quality of scale. And this is what I'm going to focus on, is the quality of scale that we can use as clinicians. With insertion torque, obviously, there are many studies showing a good correlation between long-term success and with the insertion torque number. The higher the insertion torque, the better the correlation. And most motor units that we have available today provides a measurable torque value. The unfortunate part of it is only one measurement. You can take the implant out again and insert it again to take another measurement, but how many of you take another insertion torque measurement once the implant has healed? Do you remove the implant? Do you use reverse torque? How many of you have experienced this effect when the implant hasn't integrated and you put the reverse torque on it and you peel your patient from the ceiling? So it is a non-repeatable measurement, and it only provides a reliable scale at the very beginning. It does not give you any further benefits of using insertion torque values when the implant has healed or you're wondering if the implant has healed. So you've seen this chart. We need to understand that osseointegration is a spectrum of stability, and it converts from mechanical to biologic stability over a certain period of time. And yes, the studies show that at 3 weeks, the conversion has already started. And in many patients, that conversion has completed at 6 weeks. We know that because of the experience that we have in healing fractures. Unfortunately, not every patient has started to convert at 3 weeks. And not every patient has completed that conversion from mechanical to biologic stability at 6 weeks. Some takes 8, some take 12, some take 24 weeks. And so this is what we're trying to find out. And it all starts with primary stability. So, just a quick history and the functionality of the Osstell unit. It was first introduced in 1991, as you saw from the pictures, by Neil Meredith. In 1999, Osstell was formed. In 2004, the second version started with the Osstell Mentor. And then in 2008, by then, over 4,500 units have been used. Today, we have tripled that, or Osstell has tripled that, to 12,000 units, over 12,000 units. So it is starting to catch on. The benefits of using the resonance frequency analysis: it's very objective, it's non-invasive, and it gives us a quantitative value that we can rely on as far as the bone-to-implant contact. It aids us in the decision-making of whether the implant that is placed can be treated as a one-stage or must be treated as a two-stage procedure. And it also gives us valuable objective data to decide when to provisionalize or when to load the implant. By obtaining a quantitative data on the status of the implant integration, we are then able to make key decisions as far as when to load and when to provide the definitive prosthesis. Because there are often times where we proceed from a provisional status to the definitive, and then a week later, the patient comes back with the implant and the final prosthesis in their hands. And this is what we want to avoid. When we look at the different values, what does a ISQ value of 55 tell us? It doesn't tell us much because that is one number. But what it will tell us is how we should approach this patient if that was the initial measurement. What really benefits us as far as making our decisions is the second measurement. How does that compare to that 55 that we first measured? Has it gone up? Has it gone down? Has it remained the same? Because based on that second reading, that will tell us whether that implant may be loaded or not. You've seen this chart. What it really means is that it helps me determine if the implant requires more time. That's all it really tells us. It doesn't tell us really that the implant is struggling or it's ailing or it's failing. What it tells us is that it's losing its primary stability and it hasn't achieved the biologic stability that we're looking for. And perhaps that implant needs to be treated differently. And that's the key, is to know when that ISQ value starts to drop that we need to take protective actions. So, let's just take you through this clinical scenario. Here's a patient that requires tooth number 9 removed. As you can obviously see, there's a fistula, there's edematous tissue, there's inflammation, and there is a hopeless tooth. And so we proceed to remove it, and not that you need to see how I extract the tooth, but the key here is identifying the osseous defect and determining how to place that implant. Because this patient is demanding, especially with the front tooth, that they leave your office with a tooth replaced. So how can you do that? You can do it with a flipper or a mucoadhesion prosthesis or a bonded bridge, or you can load that implant. But if you're planning to load that implant, how do you determine if that implant is sufficiently stable to support the prosthesis? So as you can see, we tried to perform atraumatic extraction with all of our cases. Sometimes it's possible, sometimes it's not. For me to immediately place the implant, I must maintain that solid bone that we find on the palatal aspect of the socket. It doesn't matter what happens on the labial aspect as far as implant stability is concerned. It does matter as far as soft tissue. But for me, primary stability is the key, and this is how I determine that. By placing the preparation site more to the palate, we're able then to engage that nice dense bone on the palatal side. And as you can see, the twist drill is struggling to get a apposition of that drill onto the bone because there is actually no labial bone whatsoever, as you saw with the pocket measurements. And so the key for me is to establish the proper shape and form in the preparation of the bone. Once I have done that, and the key that I look for is whether that drill stays in that site or not. If that drill comes out, then we will have a very difficult time gaining initial stability. But if we can establish that resistance with the twist drill, then I for sure can gain some stability. Now, we also perform soft tissue grafting, especially in these major defects that we are seeing. So this patient would be considered a high-risk patient Because if you're going with extraction and immediate implant placement with no labial bone, what do you expect from the soft tissues? It's going to shrink on you. So we naturally want to augment that site. And now we're filling the gap as far as the defect is concerned on the labial. Do we expect that to help us with the primary stability? No. What we're expecting is that graft material to help us with the reconstruction of the lost labial plate. Now we complete our packing of the graft material and we insert our implant very, very carefully. Now, at this point, what do you think the insertion torque will be? We can probably achieve 20, 25 Newton centimeters. Now, what does 25 Newton centimeters tell you? Is it ready to take immediate loading? And this is what I mean, that they do not have a reliable scale to help you determine whether it's necessary to wait or not. So here you can see we have a measurement of 73 over 78. And many of you criticize, well, how come I'm getting two numbers? Well, you have to realize that ISQ measurements is a summation of all the various measurements taken in a 360-degree value. And so you're going to see different measurements, but it's an average. And so with that high of an ISQ number, I can assure myself that we can go ahead and provide this patient with immediate provisionalization. Now note that with the placement of this permanent abutment, you don't want to over-torque this abutment screw. And so I provide resistance with my caliper, as you can see above. That allows me to prevent over-torquing and maybe loosening that implant when I'm tightening the, sorry, when I'm tightening the abutment screw. And so at this time, we hand our patient over to our Prof colleague to fabricate the provisional. Now, in this phase of treatment, we want to make sure that we minimize the removal and reinsertion of the abutment. And the reason why is because, remember, that implant that we just placed has only mechanical stability. And as you all know, if you've inserted a screw into a piece of wood, the more times you back that screw out, the looser it becomes. And so the key is not to allow the restorative events that are taking place right now to loosen that abutment. That is the reason why I torque that abutment screw down first and leave it at that. This concept really helps us to deliver the one abutment, one time principle, where we can deliver the definitive prosthesis, allow our soft tissues to mold around that the abutment, and allow us to provide the patient with adequate soft tissue contours. And so you see here we're cementing the provisional restoration in place, taking care to avoid excess cement. You can see the position of the implant. It's ideal. This is at 6 months post-implant placement, and you can see the soft tissue. Now, with the immediate load implant, I wait 6 months because there's no rush at this point. There's no need to go back in 2 months to take an ISQ value. And so we go back at 6 months, and guess what? This will tell you. You see that we reach an ISQ value of 83, 84, 85. And so this tells me that that implant indeed has integrated, even though we immediately provisionalize and immediately load that implant in this very high-risk patient. So the value of using the ISQ with initial and with the definitive restorations is the key. So the question is, can ISQ values provide a prediction for success of an implant? Or are we just rolling the dice as far as our implants are concerned that we want to immediately load or early load? And so the key for me is how that ISQ value proceeds along the definitive healing period. So in search of that magic number, if you would, we looked at my data over the last 12 years and presented the results at the 2008 Academy of Osseointegration meeting. At that time, we reported that if the implant was one stage, that is, if we placed a healing abutment on that implant, not loaded, but place a healing abutment, when the ISQ value is 50 or above, we had a success rate of 97.8%. If the ISQ value was below 50 ISQ and we one-staged it, the success rate was only 82.4. And so that gives us a little indication of where the cutoff values were. And so at that point in time, we recommended that the cutoff value be 50. And therefore, we made this recommendation that in a completely edentulous arch, if we are able to cross-arch stabilize all of the implants together, we would be able to provide a fixed provisional restoration. If they were treated as individual units, if the ISQ value was lower than 50, I would two-stage it. I would bury it and allow the implant to heal. However, if it was greater than 50, then we would consider attaching some sort of overdenture connection. With the partially dentated in 2008, we looked at ISQ values as well as the density measurements on our CT scans, because the majority of our partially dentated patients received CT scans, so we were able to measure the bone density. And so the combination of ISQ value and the bone density was used to determine whether we're going to go with two-stage, one-stage, or immediate load, or provisionalization. Finally, with a single missing tooth, and mostly in the anterior maxilla, we really didn't obtain CT scans for a single missing tooth. And so we looked at the insertion torque as well as the ISQ value. And so when we had lower insertion torques and lower ISQ values, that is a no-no for one-staging or immediate provisionalization. Whereas with insertion torque of greater than 35 and an ISQ value of greater than 55, we could feel very confident with immediate provisionalization. Now, we went back and continued to follow that data, and by 2010, we revisited our recommendations. And we saw that, again, as a clinician, I want to achieve as high a success rate as possible. And so we looked at the ISQ levels and the cutoff values, and we started to move up in 2010. And so the same recommendations, however, the cutoff point was now at 55. This is in 2010. So we converted and started to move up as far as our values are concerned. So for a partially dentated patient, if the values fell between 55 and 65, we would be very confident with one staging. And if it was above 65, that is when we started to consider immediate provisionalization. With a single missing tooth, again, we try to correlate that with the insertion torque. However, the cutoff points started to move up again. So for a single tooth, one staging, the values should be between 55 to 65, and immediate provisionalization above 70. And that is pretty much where we are today. Because when we look at that data, it really is determining how much risk you and your patient wants to take. Because if you want to achieve 100%, then you need to have a cutoff value of at least 66, 67. These are the numbers that we use for one staging versus immediate provisionalization and for the initial stability measurements. And so really, it is a matter of how much risk your patient is willing to take. If your patient is pushing you to have immediate provisionalization, and it's understandable in the front, who wants to walk around with a flipper or a bonded bridge? And so this is where we maybe go down to 60 ISQ value as far as immediate provisionalization is concerned, but understand that there is a significant drop-off as far as predictable success rates are concerned. So the sensitivity and specificity of these values should be balanced to optimize loading and placement protocols. So again, around ISQ value of 60. However, if the patient is pressing you to proceed with immediate loading, then I would use that as a cutoff value. But understand that from a cost-benefit standpoint, there is significant risk when you drop down from 66, 67 to 60 as far as the success rates are concerned. So going back to this, we want to recommend to you that we start looking at cutoff values as far as the number ISQ value of 67 is concerned. So in summary, as far as what we want to determine as far as the reliable ISQ value is concerned, understand it's a scale. It's not one definitive number. It's the transition from the initial measurement to the secondary measurement, and if need be, a third measurement. And so where do you want to take that risk? In conclusion, the ISQ values are not static. You don't want to look for a magic number, say 65, and say this is what we're going to do if we reach this. Because it really depends on multiple measurements. And there is no magic number that you need to reach in order to determine whether you're going to go with two-stage, one-stage, or immediate provisionalization. A reference scale represents levels of predictability. So if you have an ISQ value of 55, if you two-stage it, I guarantee you it will be predictable and it will be 100%. But not all patients want two-stage procedures. So if you have an ISQ value of 55 and you one-stage it, know that that success rate can drop down to about 65%. If you immediately load that, it drops even further. And so it's the scale that provides you with the ability to tell your patients, if you really want immediate load, then you're looking at a higher risk for failure. Let them decide. And the clinician has to decide with the patient what level of risk to take during their entire implant treatment. So I thank you for attending our symposium. And if you do have questions, if we can't answer it during this time period, please stop by booth number B32, and all three of us will be there to try to answer those questions for you. And thank you once again.